Good afternoon. I'm Susan Campbell, Vice President of Public Policy at Women Heart, the National Coalition for Women with Heart Disease. To this webinar reviewing the updated guideline for the management of heart failure. We are delighted to have Dr. Eileen Heesch, Associate Director for the Heart Transplant Program at the Cleveland Clinic and Chair of Women Heart's Scientific Advisory Council, presenting this important information. Dr. Heesch will review the definition, signs, symptoms, treatment, and management of heart failure according to guideline-based care. Dr. Heesch will review the current guidelines and discuss how the update to this guideline can benefit patients. This webinar will last approximately 30 minutes, Dr. Heesch's presentation, and at the end of her presentation, she'll be available to answer questions. We will give you instructions on how to submit your questions, and we're really eager to hear from you. This is a great opportunity for you to speak directly with one of the nation's foremost heart failure specialists. And so at Women Heart, we always lead with our strengths, which are our Women Heart champions. Today, we are fortunate to have Women Heart champion Eileen Dreska, a heart failure patient, community health educator, loyal heart sister, and celebrity to share her story. Many of you will recognize Eileen from her starring role with Queen Latifah in a conversation about heart failure that took place earlier this year. Eileen, thanks so much for being with us today, and I'm going to turn it over to you.
Hi, thanks. Hi, Susan. Thank you so much. Thank you, Dr. Heesch and Women Heart, for your passion, focus, and voices in the fight against heart disease through proper treatment, accurate diagnosis, education, and advocacy. My heart journey started in December 2004. At my bridal shower, I was very short of breath, I was fatigued, and I had a dry cough. I knew something was really wrong. I was misdiagnosed with depression and pneumonia, and I was sent home. My blood pressure was low, my cholesterol was low, my weight was low. I was 41 years old. Who'd have thought I was really in heart failure? I'm here today because I'm an advocate for myself when no one would listen. I hope that my story empowers you to take charge of your heart health. Thank you.
Thanks, Eileen. Your insight and experience as a heart failure survivor for 12 years, is that right?
Yes.
13 is very powerful. It's always great to have you participate in our Women Heart events. And now I'm going to turn the webinar over to Dr. Heesch. Dr. Heesch, we're eager to learn about heart failure and the updated guideline on the management of heart failure.
Well, thank you. It's a pleasure to be here, and it was really heartwarming to hear and sad to hear your story, Eileen Dreska. So actually, that brings us to the very first thing that I wanted to discuss is make sure that we all know what the symptoms and signs of heart failure is, and that really includes exactly what you experience. The most common is shortness of breath because you got fluid in the lungs, so shortness of breath is going to be the number one. And you will also, many patients, in fact most, will have also a dry cough. And that cough is often worse at night because when you lie down, your breathing is worse and there's fluid and you're coughing to kind of force yourself to sit back up. Some patients will actually have swelling in their legs, while others may have swelling in their belly and others may not have any swelling at all. Those are the most common symptoms and signs. Next. Next slide. Thanks. So we classify heart failure based on your ejection fraction, which is the strength of the heart. So all patients are to receive an echocardiogram to look at their heart. And if the strength of the heart is normal, which is the far right, called preserved systolic function. Then the ejection fraction is greater than 50% because that's normal. And the reason why the fluid builds up is because the heart is stiff. The walls are often thick and the cavity of the heart is small. In the middle, you'll see that there's the other common heart failure, which is with reduced systolic function. So these patients have weak hearts. Their ejection fraction is less than 40%. The walls are usually very thin and the heart is big and sometimes baggy. Next slide. When we see people in the office, we'll ask you how your symptoms are, and we're classifying you based on whether you have no symptoms, which is New York Heart Association Class 1. Class 2 is somebody who's symptomatic with, some activities. So they usually are people who can do most things around their house, but can't really climb a hill. Then for people who are struggling with kind of some daily activities, we label them as New York Heart Association Class 3. So if getting dressed and kind of getting around your house and moving around actually is making you symptomatic, then that is New York Heart Class 3. And Class 4 is reserved for the patients that are symptomatic at rest. So that's the most symptomatic patient possible. Next slide. When patients come in for the first time, we do a lot of testing. We'll check their urine, we'll check their blood. For their blood, we'll check a complete blood count, we'll look at electrolytes, we'll rule out diabetes with a hemoglobin A1C, we'll check their kidney function, their lipid or cholesterol values, their liver function, and we'll check their thyroid. We'll also sometimes check the fluid status by looking at a protein called B-type natriuretic peptide, and that's referred to as BNP, and others will do a similar test called N-terminal pro-B type natriuretic peptide, so NT-proBNP. And we do this for both diagnosis and prognosis, and what we're measuring is not it's a screening test for fluid. So when it's very high, you have more fluid. When it's very low, you have improved fluid values. Next slide. The only other test that we do routinely is an electrocardiogram, okay? The other two tests, which is a catheterization and a biopsy of the heart, are only done in certain situations. The catheterization, there are really two types. One is a left heart catheterization to look to see if someone's had heart attacks or blockages that provide poor blood flow to the heart. But we also will sometimes do a catheterization if we are struggling to manage your heart failure. If you are still symptomatic and we're not sure why things are not getting better, then sometimes we'll do things invasively in order to actually measure the pressures in the heart and the lung to figure out what is driving the problem. Is it the shortness of breath really the heart, or is it actually something else? Biopsies are very rarely done because most of the time we can manage patients on routine meds. So if we are doing a biopsy, we're looking for some rare disease. Next slide. So treatment is very dependent on your stage of heart failure. And this is kind of a newer classification for heart failure. We actually now are trying to prevent it as much as possible. So we basically define the stages as 4. Stage A is the very first stage where you only have risk factors. So you have absolutely no heart failure, you're just at risk. And those patients will have hypertension, coronary disease, diabetes, obesity, or the metabolic syndrome. And our goal is actually to treat the underlying disease so that you'll never have heart failure. In appropriate cases, if you have like high blood pressure, we'll use some medicines that we use for heart failure, but that's really only if you need them. So that would include an ACE inhibitor or an angiotensin receptor blocker, but that's only if you needed them. Next slide. Stage B means that you actually have structural heart disease. So there's something wrong with the heart, but you do not have heart failure symptoms. So you're not like Eileen Dresnick, who had shortness of breath. You're actually asymptomatic, walking around with a problem, but not having any symptoms. And that could be because you've had a heart attack. It could be because the heart could be just weak in general without a heart attack, or you could have just valvular disease. So the doors of the heart may be abnormal and leaking, but not causing you to be short of breath. For these patients, we actually do start two medications. We start either an ACE inhibitor or an ARB, which I'm going to go over later, and a beta blocker. And these medicines lower blood pressure, but the reason we're giving them is to try to prevent the heart from getting weaker. So kind of the side effect is lowering your blood pressure. Our goal is actually to prevent the heart from getting weaker. Next slide. Stage C is actually what we refer to as heart failure, people who are symptomatic. That is the stage for which all of our guideline therapy really is most important. So these are the patients actually that have that class 2, 3, or 4 symptoms, and they're going to need diuretics, which are water pills to help get rid of fluid. They're going to need ACE inhibitors, ARBs, beta blockers, aldosterone antagonists, digitalis, hydralazine, and nitrates. And we're going to go over all these different things in the next few slides. But this is what we refer to as stage C, when patients actually have heart failure with symptoms. Next slide. And for completion, I'm going to mention stage D, which is when medications no longer work. The patient had stage C, they already had symptoms, and yet medicine is no longer working. And for those patients, we offer either heart transplant or mechanical hearts. And if that is not possible, then unfortunately we do need to actually do hospice or consider experimental drugs. Next slide. So this is just letting people know that, I mentioned that we, for symptomatic heart failure, we use a lot of different drugs to help prevent the heart from getting weaker. The first line of drugs that were ever found to heal the heart were the ACE inhibitors. And there's a lot of them here as examples. And all of them are thought, to be similar, and they all work. And they block a hormone in this thing called renin-angiotensin syndrome, and that this actually helps prevent further weakening of the heart. For patients who have, it's really a preference now. It used to be a guideline, but right now it's a preference if they can take either an ACE inhibitor or a drug similar to that called an angiotensin receptor blocker. And the three that are used are either candesartan, losartan, or valsartan. Next slide. Okay, well, these medications, the angiotensin receptor blockers, are similar. They're almost like cousins to this ACE inhibitor. They're not all thought to be the same, though. So each one of them actually is slightly different from the other, and they've all been tested, and the ones that I've mentioned all have been shown to work. And they work both in women and in men. Next slide. The next line of drug is called an aldosterone antagonist, and these medications are actually medicines that make you pee. They're water pills. But at the doses we give them, they do not make you urinate, or it's very rare. They're very low doses. They actually prevent you from losing your potassium, so that they keep your potassium in your body, and they also prevent scarring of your heart. When we talk about the other two drugs, the ACE inhibitor and ARB, they're blocking a hormone, and anything that kind of makes it through that cascade that is not blocked is further blocked with this drug. So it's along the same pathway that it is helping out. But I think the most important thing to mention, it doesn't make you feel better. It's actually a drug that helps you live longer. And it's not to be given if patients already have high potassium, defined as a potassium greater than 5, or if they have kidneys that are abnormal, so that the kidney function in a woman needs to be less than 2, and in a male it needs to be less than 2.5. Next slide. Hydralazine and isosorbide dinitrate are medications that are used in people who have bad kidneys that can't be on the other drugs. That's one indication. And the second is that it has been found to reduce mortality, improve quality of life, and reduce hospitalizations for African Americans. So it's used specifically for that race for those benefits. Next slide. Beta blockers are among the strongest medications we have to heal the heart. They actually block our adrenaline. So our adrenaline is still being made, but it blocks the heart from seeing adrenaline, so it slows the heart down. It also can lower the blood pressure. The three medications that have been shown to be effective are carvedilol, metoprolol, and bisoprolol. And two of these have been approved in the United States, which is the carvedilol and metoprolol. Next slide. And they have also been found to work in women. For completion, I'm just going to mention that in addition to medications, we do have devices that are necessary for heart failure. Next slide. We use defibrillators to prevent death, and we do so if you actually have the function of your heart is less than 35%. And you have symptoms of heart failure, okay? And so this is to prevent death. We don't really know who is needing it. We give it to everybody to prevent a problem. And then in special situations, we do use pacemakers on both sides of your heart if the electrical system is stretched. And we define a stretched electrical system as a QRS greater than 150 milliseconds. And these are for, again, patients whose heart function is less than 35% and who are symptomatic. Next slide. And for completion, I mentioned that we do have mechanical hearts, and I always thought it's kind of neat to see what they look like. So these are the three that are FDA approved, HeartMate 2, HeartWare, and HeartMate 3. And you can kind of see in an X-ray that there's pieces of the devices actually, next to the heart on the far right-hand corner. You can see the device, and in fact, right above the devices, you see people's defibrillators. Next slide. So what about the new guidelines? So the new guidelines, they were updated in 2016, and they added 2 new medications. So this was really special because it was the first time we had 2 new pills that we could be using to improve patients. The first drug was called an angiotensin receptor neprilysin inhibitor, and because that's such a long, name, we've nicknamed it ARNI, A-R-N-I. The drug that was studied was called Entresto, and that is a combination pill. So that pill has 2 drugs in it. One is valsartan, which was that angiotensin receptor blocker that we saw earlier, and then a new drug which was added into that called sacubitril, which is a neprilysin inhibitor. Both of these medications lower blood pressure, and the neprilysin inhibitor does so by preventing breakdown of special proteins called natriuretic peptides and bradykinin, so that these medicines actually do significantly lower your blood pressure. The next drug that was added to our regimen was called ivabradine, and it does something very different. It actually reduces heart rate. It does not affect blood pressure, and it does so only if you have normal rhythm, and it inhibits this thing that seems really strange called the funny current in the sinoatrial node, which is basically the pacemaker of the heart. So it can block that and slow the heart down. So we're going to go to the next slide and talk about when do we use them. So in our guidelines, they have rules as to when you're allowed to do something or when they think you should consider it. So a class 1 indication means that all doctors and caregivers should use this unless there's some contraindication. So this ARNI, or angiotensin receptor blocker neprilysin inhibitor, has a class 1 indication, which means that it should be used if anyone has class 2 or 3 symptoms, which is mild or moderate, and their heart function, the ejection fraction, is less than 40%. Okay? It is not allowed, which is a class 3, meaning that you cannot do it, if they already are allergic to the medication, so clearly you wouldn't give it then, but you also have to wait 36 hours if you're on an ACE inhibitor. So if you are on one of the other drugs, you have to actually wait 36 hours before starting this medication to prevent complications. Next slide. So why did they add this drug? Why did this come onto the market, and for us to actually be told that this is the, a really excellent medication to help our patients? And the reason is that there was a very large trial called the Paradigm Heart Failure Trial that randomized patients that were symptomatic and had an ejection fraction less than 40 to either actually this new drug or enalapril. And what they found, they were looking for a combined endpoint of preventing death, cardiovascular death, or hospitalization. And they had over 8,000 patients, and 23% of them were women. And they found that this actually drug did prevent a combined endpoint of death or hospitalization for all their patients. This is really a huge finding because it meant that beyond what we were already doing, this medication may have extra benefits. They looked in different subgroups to see whether or not it benefited, different people, so that it's not just for everyone, but it could be in special subgroups. And for most of those subgroups, there was a benefit. I think it's important to mention, though, that there were very few African Americans in that study, so it was about 5%. So there's still some subgroups for which we don't know whether or not this drug is ideal, but we have no indication to say that there's any harm. It's just that there are some subgroups that were not studied as well as others. Next slide. So Rabidine is the other new agent that was recommended. And as I said, it reduces the heart rate by blocking this funny current in our pacemaker of our heart. Instead of having a class 1, which means you absolutely have to use it, it's called a class 2A indication, meaning that it's reasonable to choose. And they recommend that you consider it in patients who are symptomatic, class 2 or 3. The ejection fraction should be less than 35%. These patients need to already be on regular medications, and they have to be taking already a beta blocker that slows the heart down, and they have to have a normal heart rate, a normal rhythm, with their heart rate being greater than 70 beats per minute while they're already on other medication, including the highest tolerated beta blocker. The reason why we were told that we should consider this medication was based on a trial called the SHIFT trial that also had a combined endpoint of cardiovascular death or heart failure hospitalization. However, when they found the benefit of this drug, they realized that the majority of the patients who benefited had reduced hospitalizations, and there was very few deaths that were prevented, so that the real benefit is to reduce hospitalization. Next slide. So in conclusion, heart failure affects 6.5 million Americans. That's why we think it's very important. And more than 50% of these are women. Hypertension is the most common risk factor, but coronary disease is also a significant relative risk. The diagnosis is by a constellation of symptoms and signs, so it's not by an echo, okay? The echo helps define what kind of heart failure you have. And you treat based on the stages and your ejection fraction. The 2 new drugs that we have that have been entered into our guidelines is called an ARNI, which is an angiotensin receptor blocker, and a neprilysin inhibitor. And the other drug is called a Rabidine, which is a medication that slows the heart down by inhibiting the funny current. And then the last thing I want to mention, which really wasn't discussed, is that this is kind of an exciting time because even the mechanical hearts that I showed you on those chest x-rays are now finally small enough to fit in women, so that we're able to rescue women and men, and so we have made major headway in our medical and device therapy, and that's it.
Okay, thank you so much, Dr. Heish. Now we're going to open the lines to take your questions for Dr. Heish, for Eileen Dreska, or for the Women Heart staff. It's my pleasure to introduce Milan Anderson, who's the Administrative Associate for the National Hospital Alliance, who's going to assist you with submitting questions.
Good afternoon, everyone. In the upper right-hand corner of your screen, you will find a rectangular box containing various icons known as the Grab tab. Locate and click on the orange arrow icon at the top of the Grab tab to expand your control panel. Find the pane labeled Questions in the bottom half of the control panel. You will see a box containing the words Enter a Question for Staff underneath the Questions pane. This is a box to submit questions. If you do not see this box underneath the Questions pane, click on the arrow adjacent to the word Questions, and the box will expand below. Type your questions into the box and click Send. Your questions will come to me and will not be seen by anyone else. I will read the questions I received out loud in the order that I received them, and one of our panelists, either Dr. Heish or Eileen Dreska, will answer them. Feel free to submit as many questions as you want. So locate the question box and submit away. We seem to receive a question already from Rita Ray. What are the 3 main things that you recommend to manage heart failure? Dr. Heish, I think this one's for you.
Yeah, I think that the 3 main things, I would say medications are really very, very essential to prevent progression of disease. And I think it's also important to let people know, especially when they're newly diagnosed, that with time and medication, at least 1 out of every 3 completely return to normal function. So it is very important that you take the medications and follow the instructions of the physician. So that's one. The second is actually diet, that it's very important to prevent fluid and manage your heart failure with your diet, so that we need to actually reduce the amount of salt. And I think I have a tendency to just grab what's easy, right, to eat. And that's usually foods that are either frozen or they're canned, and all that is preserved in salt, so they're no-nos. And so we need to keep our salt content actually less than 2 grams a day, but really you can do that by just avoiding those that are frozen and preserved in salt and those that are canned, and just look at the content. As well as when I say that our diet, it includes how much we drink, right, of fluid. So we want to limit the amount that we're taking in, because we don't want to fill up our lungs. So we want to limit it to 2 liters a day. Those are the 2 most important. The third is actually to really have a positive outlook. I think the one most remarkable case I've ever seen was a lady whose strength of her heart was 10% after a heart attack. And I got to meet her years after her event. I was just the doctor when I first came in, but she had been a patient longer than I had been probably a doctor. And she was about 6 years old at the time, and she was a black diamond skier, and she didn't stop skiing. And she continued to do so much activity. It was unbelievable. It was very hard to always organize her clinic visits because it was around her ski trips. So that she really remained very athletic, she remained remarkable, and so that the ejection fraction does not define your prognosis. It makes you at higher risk maybe of something going wrong, but actually really how well you're doing defines how well you're doing.
And we have another question from Luann Weber. Can you please talk about the mortality rate for CHF?
Yeah, I think that's the one that scares people the most. I think that, you look on the web and it says 50% of the patients will die within 5 years, right? That's what everyone sees. That's what everyone hears, and that's what everyone fears. And I think a lot of that data is very old. I really do. A lot of that data occurred before we had all these new medications. They definitely were actually done before we had, the latest medications and before we had biventricular pacemakers. So that is not true, because I can tell you that I've been doing this for 13 years, and most of my patients have remained with me the whole time, and I expect to grow old with them. So I think that my research is actually on trying to predict death, and I think what I've learned is that you can't predict it as well as we'd like. I think that the factors that really define death are things that are hard to put into a risk model, which is the patient who actually is being frequently hospitalized, is the patient who's doing poorly. If you can get them back on track, perfect. But if you continue to be hospitalized, then we're going down the wrong course, and those people are the ones who are at highest risk of dying. Prior to that, the lady that I mentioned with an ejection fraction of 10%, she had remained at 10% for more than 15 years. So that's now 5-year, 50% mortality. That didn't happen to her. And the only thing that is actually making her symptomatic and getting worse right now is the fact that she's developed cancer and had to start chemotherapy after having surgery. So with an EF of 10, she actually went through a major debulking operation, and what has really created the biggest problem is the chemotherapy in a patient who did have a weak heart. So I think to answer your question is I can't. And I think you need to know that. Everyone gives people their best attempt, but it's really very challenging and probably inaccurate.
In part 2 to Louise's question, how does the disease progress to the end stage?
People can remain asymptomatic or mildly symptomatic for a very long time. And for people who actually start to become hospitalized, that's when you know you're going down that downward course. So with regards to how do you feel, I almost ask, well, most of my patients will say that they actually get more and more shortness of breath with less and less activity, so that they're developing symptoms frequently. Initially, we try to actually increase the water pills, and there sometimes reaches a point where the amount of medicine is not enough. For those patients, we are actually, that goes into that stage D, where medicines are no longer working, for which we actually start to explore, are they a candidate for heart transplant or a mechanical heart? Or do they want to try an experimental drug? Or do they want to, to go change the entire pathway to actually just comfort care? So that extreme fatigue, when people are dying, they have not just fatigue a little, but extreme fatigue, because it's fatigue that actually prevents them from being able to do anything because the heart isn't pumping adequately. That is the symptom for somebody who is dying. But their symptoms before that are more clear, right? So that it's not that all of a sudden one day you wake up with just fatigue. It's that you've been having heart failure and shortness of breath and leg swelling and belly swelling, so that it's a progression.
Also, in the first question that you answered, you mentioned the fluid volume. Can you further explain what fluid volume means?
Fluid volume. When I talked about how much to drink, is that what they're referring to?
I think so, yes.
So the amount of fluid that we're allowed to really drink when the heart is not pumping adequately should be limited to about 2 liters. So when you think about buying a Coca-Cola bottle, those big 2-liter Coca-Cola bottle, that's it for the day. So, some people will carry around a water bottle and kind of monitor so that they know exactly how much they're taking. But the amount that is kind of safe to consume is 2 liters, and the 2 liters would be equivalent to a 2-liter Coca-Cola bottle. I'm not sure if that's answering your question.
This is Susan. Here's another question from our board chair, actually, Evan McCabe. How do you diagnose heart failure when you have a preserved ejection fraction greater than 50%? Does it affect the BNP blood test like regular heart failure?
Yeah, I mean, it again is symptoms and signs because you're looking for evidence. that in addition to someone saying that they're short of breath, that when you listen to their lungs, that there's sounds that we hear as crackles, and that we look at the neck and see if the neck veins are distended, showing that the heart is unable to keep the fluid pumping forward, so it backs up, and we can see that in the neck, and that we look for swelling in the legs and swelling in the belly. So the signs that we're looking for on exam are identical whether the heart is weak or strong, and that is why we have to do an echo, because we cannot guess at the strength of the heart by looking at you, but we can look at you and determine that you have too much fluid, that you have heart failure. The BNP test is helpful for both weak and strong hearts. It's used for diagnosis, but it is not a necessary test. You can make the diagnosis without that based on your signs on exam and your symptoms.
And Dr. Heesh, another question for you. How do I know if I'm a good candidate for cardiac rehab?
For cardiac rehab, so I think everybody who has heart failure is supposed to exercise. So a good candidate is anyone who is willing to actually go to cardiac rehab. It is now actually covered by insurance companies to at least do it through one session. And it makes people feel better, it gives them confidence, and there's a lot more improvement from there. But it is very helpful. So everyone's a good candidate.
Another question, if a family member is in denial that this could happen to them, how can we educate without scaring them? This is a serious to put their health first. My sister has high blood pressure but don't put time to treat herself. They told me my heart disease is through family.
Yeah, you know, high blood pressure I refer to as a silent killer. I bluntly tell people that. I have had many patients that I've met with malignant hypertension. It's usually, you know, a family member who is in the health field brings their sister and brother or sister and say that, please help me with my family member, it's genetic, and they don't really understand. Well, why do they not understand? Because they have no symptoms. It is a silent killer. It actually is probably one of the most common causes of a stroke. And I think when I try to remind people why they need to take their medication, I think, you know, heart failure doesn't seem to seem real to most people. Everyone does fear a stroke. And I do use that because that is the most common cause of a stroke is high blood pressure. And it is more common in women than men. And so I remind them they do not want to be impaired and that we need to do this to prevent something as horrific as that.
I have another question. If my mom suffers from cardiomyopathy, what is the likelihood that she will develop heart failure? What is the likelihood I would also develop heart failure?
That's a very good question. So if someone has already been defined as having a cardiomyopathy, then by definition, that is stage B, right? It's not a risk. They've already have it. There's something wrong with the heart. And what you're saying is that they don't have symptoms. The likelihood is probably high, but we really don't know how to answer that question because the only way to know how people do that are asymptomatic is to test everyone in a city, everyone. Find out who has it that didn't even know they had it, and then follow them over time, right? Because there's no reason to do testing to discover it in an asymptomatic patient, so it really has to be by accident. And so we don't really have studies that have done that. We do fear that a patient who already has a weakening of the heart will likely develop symptoms over time, but we don't have really enough research to follow that to answer it. I think the next question that you asked, which was important, is can I get it? And you know, the answer is about 20% of the patients who have heart failure have a genetic reason to have it, that it is called familial, so it is passed on. And many times I'll meet somebody who said, no, I'm the first in my family, no one else has it, and we think it's a virus that caused it. And that can be fine at the time that we tell you that, But if we find out more family members later develop it, then it is not likely the virus. It's the fact that others now have been tested and you do have a genetic cause. At that point, I would seek genetic counseling and try to figure out what is the genetic defect, if possible, so that we can actually prevent more people from either getting it or prevent them from getting worse by actually identifying them earlier.
Okay. One more question, Dr. Heash. So if I'm a patient with heart failure and I'm taking my medicines and I'm feeling better, can I stop taking my medicines?
That's a good question. Thank you for asking. So no, I wouldn't like you just to stop it just because you felt like you wanted to stop it. That needs to be a very serious conversation with your doctors. If the heart is weak, then you absolutely need to take your medicines for life. There's no question that research has shown that is the best way to prevent things from getting worse. When the heart becomes normal, and I told you 1 out of every 3 patients, based on our studies, 1 out of 3 or 1 out of 4, it's going to actually have normal heart function afterwards. You know, what we don't know is what we should do in those cases. And you'll see variations. Some doctors will say you don't need the meds anymore. Other doctors will say stay on meds for life. And whenever you have a situation where you get different opinions, it's because there's no research to define what is the right answer. Anecdotally, when patients actually stop their meds when their heart is normal, about 20% of the patients actually will deteriorate again and develop a weak heart later that does not respond very easily or at all to medication, so they end up in worse shape. That group is likely still now to be the genetic cause because it's that 20%, and so those patients don't do as well. So that's a very serious conversation to have with your doctor and before stopping your pills. And it's probably best to do so with their guidance and with their willingness to follow you over time to make sure you remain well.
Okay, Dr. Heash, one last question for you. For Eileen. Oh, one last question for Eileen Dreska. Eileen, are you still there?
Yes, I am.
And one last question for you. How does Women Heart help you live with heart failure?
Well, one of the biggest components that Women Heart has offered is the support system through the Women Heart Champions. They've really educated me and helped me to understand that it's being diagnosed properly and being educated and getting support from my sisters and being an advocate for myself.
All right, well, thank you so much. Boy, that was a lot of information, and it looks like we're running out of time. I want to thank everyone who attended the webinar. I want to thank you, those of you who put in questions. If you, the minute we hang up, think of a burning question that you wanted to ask, please email us here at Women Heart. You can use the National Hospital Alliance email address in the email you received to register. You'll also be receiving a follow-up email from us with a link to this webinar recording in case you want to watch it again or share it with any of your friends or family members or colleagues. Eileen or Dreska or Dr. Heash, any closing remarks?
No, but thank you very much for this opportunity to talk about heart failure.
Yes, thank you so much for everything that you do, Dr. Heash and Women Heart. We really appreciate it.
Great. Well, thank you so much. Take care, everybody. Bye-bye.
Bye-bye.
Bye.